So the hypothalamus manages the release of hormones as well as the autonomic nervous system. So it releases CRH, TRH, GnRH, GHRH. And then it also releases somatostatin, which inhibits growth hormone and TSH, and it also releases dopamine that inhibits FSH and LH, as well as inhibits prolactin release from the pituitary. And then we have the pituitary, which produces and releases hormones, such as growth hormones, metabolic hormones, and reproductive hormones. So we have two parts of the pituitary. We have the anterior, which is the front. It releases growth hormone, which stimulates the growth of bone and muscles. ACTH, which is adrenocorticotropic hormone, which stimulates secretion of adrenal hormones. Then we have thyroid stimulating hormone, or TSH, which synthesizes thyroid hormones such as T4 and T3. And then we have our follicle stimulating hormone, FSH, which stimulates ovulation as for females, and then it stimulates sperm for men. And then we have luteinizing hormone, LH, which releases the oocyte or egg in females, and then it stimulates testosterone in males. And then we have prolactin, which stimulates breast milk production. And then on our posterior, we have our antidiuretic ADH, which increases absorption of water in the kidneys. And then we have oxytocin, which stimulates contractions in the uterus.
So it's a tumor on the pituitary gland. It makes up about 10% of intracranial tumors, and as it's growing, it replaces the tissue of the pituitary gland with tumor cells. Signs and symptoms include vision change, head tilting, skin changes, strabismus, which is like lazy eye, where it goes this or this way.
Thank you for that demonstration.
Well, increased ICP, rhinorrhea, decrease in testicle size and decrease in breast size. Complications include diabetes insipidus, hypopituitarism, loss of smell, shock, coma, and death.
Beautiful.
Treatment includes VTE prophylaxis, hormone replacement, chemo, radiation, surgery. Diagnostics, lumbar puncture and CSF analysis, prolactin levels, and brain CT or MRI. Nursing interventions, IV access, support airway, breathing, circulation, increased ICP prevention and coping mechanisms. And patient education includes the disease and treatment, avoid coughing, sneezing, and bending post-op to decrease ICP. Medical alert bracelet, and report persistent postnasal drip and or swallowing.
Beautiful.
Okay, so for diabetes insipidus, our patho, it's a decreased secretion of ADH, and the kidney becomes unable to respond to ADH, results in excessive intake, which then causes hypopolyuria or hypotonic polyuria because it's too diluted. Signs and symptoms: polydipsia, polyuria, weight loss, dizzy, weak, and fatigue, like from dehydration, constipation, decreased libido, and erectile dysfunction. Okay, so some complications of this: if we don't get it treated fast, our patient's going to become hypovolemic. They're going to have hyperosmolality, level of consciousness changes, bladder distension, hydronephrosis, and hydroureter. So the treatment, you see, well, first we're going to do some diagnostics. These diagnostics are going to be a urinalysis, a CMP, a serum vasopressin, and an MRI. Once we get our labs and we have diagnosed them, we are going to treat with a diuretic. I know, it's weird. Hydrochlorothiazide.
Do you remember why?
Because it helps the kidneys respond to the ADH. Right?
Yeah.
Is that it?
Yeah.
Yeah.
That's
Okay.
what the book said.
And NSAIDs, carbamazepine, an anti-epileptic, and D5W. Okay, so once we treated them with that, now we're gonna have our nursing interventions. We're gonna assess their hemodynamic status. We're gonna encourage fluids, daily weight, and monitor for fluid volume excess caused by us. So once our patient's been treated, we're gonna wanna educate them on signs and symptoms of dehydration, fluid volume excess. We need to let them know they need a medical bracelet and they need follow-up care.
All right, so SIADH, syndrome of inappropriate antidiuretic hormone. So it is classified as excess ADH secretion with absence of ADH stimuli, which increases water reabsorption, resulting in hyponatremia and slightly increased extracellular fluid volume.
Okay.
Signs and symptoms include increased heart rate, disorientation, seizures, coma, decreased deep tendon reflexes, and Cheyenne-Stokes respirations, which are periods of hyperapnea and
Apnea. Completely.
and complete apnea.
Yeah.
And then we've complications, water intoxication, because they're not able to get it off, cerebral edema, severe hyponatremia, seizures, coma, and death.
So in SIADH, they can't get rid of it
Correct.
because
And
there's.
versus DI, they're getting rid of too much.
Okay, so in this one, it's all staying in because they have excess ADH, which is the antidiuretic hormone.
Yes.
Okay, got it.
So it's causing increased
An
water reabsorption.
antidiuretic, yeah.
And then our diagnostics our serum osmolality would be less than 280. We'd have a elevated serum ADH, not HD. A serum sodium of under 135, a urine sodium of over 40, and then we would do a chest x-ray and a brain CT or MRI to rule out tumors.
Yes.
Our treatment would be to correct any underlying causes as well as a loop diuretic to get that fluid off quickly.
I'm having some trouble with the connection. Please try again in a moment.
And then our nursing interventions, we would do VTE prophylaxis, fluid restrictions, seizure precautions. And the patient education, you would want to teach them about fluid retention and monitoring their weight every day. Then they would report sudden increase in weight gain, level of consciousness changes, and shortness of breath.
Okay, so now we have Addison's, an adrenal disorder. The patho, it's a partial and complete autoimmune destruction of the adrenals. Signs and symptoms, if our patient has that, you could look for decreased coordination, decreased auxiliary and pubic hair, bronze skin appearing in like patches around the eyes, feet. It's not like an overall bronze skin. And then vitiligo, which is the lack of melanin or color, so you become pale. They would have a weak and irregular pulse and probably hypotension. So some complications, if we don't start treating these signs and symptoms right here, we're gonna have hyperpyrexia, fever, psychotic reactions, shock, coma, death. Okay, so we're gonna try and treat this patient. We're gonna treat them with D5 and S. That is gonna be immediate treatment right away, and then we can move on to corticosteroid replacement. And this would be a long-term treatment for constant replacement.
Likely the rest of their life.
Yeah. So some diagnostics to make sure this is what they actually have. We're gonna have ACTH serum. There's gonna be no change.
From morning to afternoon.
Is what?
From morning to afternoon.
Okay, so the ACTH serum, there's gonna be no change in levels in the morning and afternoon. The cortisol in the serum in the morning, it's probably gonna be less than 10, and then in the afternoon it'll be less than 3. The serum sodium and glucose is probably going to be low. A CMP would show decreased potassium, calcium, it would be increased. So they're going to have increased potassium, increased calcium, and an increased BUN. Their hematocrit also going to be higher. Renin and TSH is also going to be raised.
Sorry, I'm having trouble with the connection. Please try again in a moment.
And then another thing we can do for them is a chest x-ray and a CT. So once we did that, our nursing interventions, after we ruled in Addison's, we're going to increase their sodium, increase their protein, and have a decreased potassium diet. We can do daily weights for them. They should be on a telemonitor 24/7, and then INOs every day. And I think that's all of it.
Patient education.
Oh, patient education. So we're going to teach them ways to decrease their infection risk, usually starting with hand washing, decrease the stress, self-taught med administration. We want to make sure these patients know how to take their meds when they get home, as well as the side effects and patient teaching. And we should teach our patient to contact the HCP if they have persistent vomiting or if they cannot tolerate oral fluids.
Right. Ready?
Yeah.
So we have Cushing's. Cushing's is the opposite of Addison's. So the patho is they're going to have increased cortisol is released, which leads to an increase of circulating cortisol. Signs and symptoms include thinning hair, moon faces, hirsutism. They'll have a buffalo hump, central obesity, so more in this area, muscle wasting, petechiae. They'll have thinner extremities, acne, and emotional lability. Complications include an adrenal crisis, osteoporosis, diabetes insipidus, diabetes mellitus, frequent infections, hypertension, ischemic heart disease, heart failure, and psychiatric problems. It's diagnosed with a CBC with differential, so we'll see a CBC of equal to or greater than 11,000, or a white blood cell, I'm sorry, would be equal to or greater than 11,000. We would see a decreased potassium and calcium on a CMP, and then the specific test for this disease is the low dose dexamethasone suppression blood test, where they administer dexamethasone and see how their body uses it. And then their treatment's going to be decreased steroid use if they are using corticosteroids, because one causes prolonged steroid use. We will increase their potassium, increase their protein, decrease calories, and decrease sodium in their diet. And then if it's caused by a pituitary tumor, then we would do, they would go through radiation and surgery. And surgery to remove a pituitary tumor could cause Addison's, so then they'll have the whole other end of the spectrum. Nursing intervention, so obviously we're going to give meds that are ordered. We're going to monitor their vitals, their I's and O's.
There you go.
Their daily weights, monitor their electrolytes, skin checks, and coping. Due to their central obesity, they'll have a large penis that they can have some significant skin breakdown here. And then patient education, monitoring their weight, increase their calcium in their diet to prevent osteoporosis, and then infection prevention. Hey Bree, what's the difference between a functional and non-functional pituitary tumor?
Okay, so you see we got these two types, functional and non-functional tumors. So functional, they're functioning, not positively, but they're functioning to produce excess hormones. Non-functional, they do not produce any excess hormones, but they can still decrease normal hormone production by our body. So these are bad, and these are both bad. Ready?
Yes.
All right, so we have hypophysectomy, which is a surgical excision of all or part of the pituitary gland. It may be done transsphenoidal, endoscopic transnasal, or stereotactic radiosurgery. So for pre-op care, we would obviously verify informed consent. we would instruct the patient that they need to start hydrocortisone at least the day before surgery or as the provider requires. NPO for at least 8 hours prior to surgery. No anticoagulants or aspirin per provider orders. And then when they get there, we want to explain to them their post-op care before the patient goes under anesthesia. We would want to make sure that they have a baseline visual field test to see what their vision is before they have brain surgery. And then we would want to do their pre-procedure assessment, such as allergies, vital signs, and then we would administer any pre-op meds that are ordered. For post-op care, we would administer meds that are ordered. Patients need to be on bed rest for at least 24 hours before we start ambulating them. You'll elevate the head of the bed to encourage drainage. And then we would do another visual field test to see if there's any changes from removing that tumor. Pain assessment, and then administer pain meds as ordered. Assess for complications such as diabetes insipidus, SI-ADH, and a CSF leak. And then you'll monitor their drainage for signs and symptoms of infection or glucose. The glucose can indicate a CSF leak.
Hey Bree, can you tell me all about a pheochromocytoma?
Sure I can. Okay, so a pheochromocytoma. Hi. Okay, so the patho, it's excessive catecholamine production from an adrenal tumor. This leads to stimulation of alpha and beta adrenic receptors. So the signs and symptoms, your patient has pheochromocytoma. You're gonna see pretty much increased everything. Increased blood pressure, increased heart contractility, increased breakdown of glycogen, which then increases the glucose production. We're gonna have tachypnea, pallor, hyperhidrosis, which is excessive sweating, and possibly seizures. Hopefully we can prevent those, but okay, so some complications. If we do not treat them fast enough, they could go into stroke, retinopathy, kidney damage that is irreversible, pulmonary edema, heart failure, and aneurysm. So for our diagnostics for this patient, we're gonna see an increased serum of metanephrine. We're gonna see an increased urine vanilli-mandelic level from a 24-hour urine. Increased calcium and glucose is gonna be present. And the abdomen and pelvis can be scanned with a CT and MRI to diagnose, rule in, rule out. Okay.
Hey Bree, where is the location of this tumor?
It is by your kidney, on top of your kidney. And your kidney looks like a little bean like this. And then it's gonna be like that. There we go. All right, so our patient has this tumor right here. Now we're gonna try and treat it. We're gonna try and control their blood pressure before they go into a hypertensive crisis, which can be fatal. VTE prophylactic, that's for any of our patients in the hospital. Radiation to try and get that tumor smaller. We're gonna increase their sodium intake if they are going in for surgery or radiation on it. We are going to try and increase their rest during an attack of increased blood pressure. Beta blockers, non-selective and selective, and calcium channel blockers. Okay, so before we move on to the nursing interventions and patient education, at-risk people are pregnant women, patients who have a family history of it, and patients who have a family history or a history of inheriting a rare disorder. Okay, so nursing interventions, because we are treating their high blood pressure with beta blockers, calcium channel blockers, we need to watch for orthostatic BP, so make sure your patient rises slowly, watch for dizziness, there's gonna be a fall risk. Monitor for a hypertensive crisis, this is huge. If we see this, we need to have our meds ready to treat that. It is phentolamine to treat the hypertensive crisis. Encourage bed rest. Okay, patient education. We need to teach them the signs and symptoms of that hypertensive crisis that we're waiting on, or we're watching for. Paroxysmal attack prevention, so probably decreasing stress. Signs and symptoms of adrenal insufficiency our patients need to be aware of, and our patients need to know how to check their blood pressure at home. And that's
You're such a great teacher.